Good afternoon and welcome everyone. And thank you for joining us for our 2021 webinar series. I am Dr. Althea Hicks, Grants and Programs Manager for Jonas Nursing and Veterans Healthcare, the signature program of Jonas Philanthropies. Please note that this webinar is being recorded. Jonas Nursing and Veterans Healthcare was founded by Donald and Barbara Jonas, and our program works in partnership with schools of nursing across the country to identify and invest in high potential doctoral nursing scholars. We are the first and only privately funded program in the nation with a presence in all 50 states. And we're focused on the commitment to the nursing profession and veterans healthcare with over 1,200 scholars funded to date. Please be sure to follow us on Facebook and LinkedIn at Jonas Philanthropies, on Twitter at Jonas Impact, and on our website at www.jonasphilanthropies.org. Check out our Jonas Philanthropies website for our media library and other upcoming events. And as a reminder, please use the chat function to submit your questions, and please make sure your volume is muted, and please turn your camera off. Today's webinar is entitled Child Mental Health During COVID-19, How a Pandemic Can Lead to New Solutions for Old Problems. Our speaker today is Dr. Kristen Choi, who's Assistant Professor at UCLA School of Nursing and the UCLA Fielding School of Public Health. We're also happy to say that Dr. Choi is a Jonas AAN Policy Scholar with the American Academy of Nursing. Let's welcome Dr. Choi.
Good afternoon, everyone. And Althea, thank you so much for that kind introduction. I'm really pleased to be with you all today to talk about some of the research coming out about what is going on with mental health for children and teens during the COVID-19 pandemic. And before I start, I do want to just echo what Althea said and thank the Jonas Foundation for their support of me and my work. My fellowship with the American Academy of Nursing was a really wonderful learning experience and really helped launch my own career in advocacy for nursing. So I'm very glad to be a part of the Jonas family here and to share some of the work that I've done. I'm going to be talking today about mental health during COVID-19, and I want to invite all of you to participate in one small way in the presentation. In this light blue block box on the screen, I have an audience question. How can we promote resilience and mental well-being among children and adolescents during the COVID-19 pandemic? On your phone or computer browser, if you go to this website, menti.com, and enter the code listed here, you can enter any words or phrases that come to mind in answering this question. It's going to put together actually a word cloud of the responses of our whole group today, and I will show the results a bit later in the presentation. So again, go to menti.com to enter any words or phrases in response to this question, and I will have the question on the first few slides if you want to answer at any time during the presentation. With that, I'm going to move over to sharing my slides. And Althea, it looks like actually I need you to stop sharing before I can share my slides here. Perfect. Thank you so much. All right. So what I'm going to talk about today, first, I'm going to talk about the pre-pandemic context for child mental health. Unfortunately, the pandemic issues are not new, and they came at a time when we were dealing with a real crisis of child mental health to begin with. Then I'll talk about emerging research on the COVID-19 pandemic, what we know about how it's affecting children and teens, and some examples of some work that I've done in this area. Then I'll talk last about solutions that I see, how we can leverage the pandemic and the way it has shown light on problems that were pre-existing to really improve child mental health care in the United States, as well as what we can learn about child mental health nursing and implications for practice. So starting with our old problem of child mental health. Child mental health was certainly a big problem in the pre-COVID world. When we talk about mental health for children and teens, we tend to use a number of different terms, but really to lump a lot of different things together. You may hear the terms child mental health or child behavioral health, child emotional health, and often we put all those things under one umbrella. But when we talk about child mental health in terms of data, generally this refers to mental disorders, things like depression, anxiety, ADHD, post-traumatic stress disorder, oppositional defiant disorder, etc. And it also refers to various kinds of developmental disabilities, things like autism spectrum disorder and pervasive developmental disorder. It also refers to substance use and abuse disorders. So all of those things go under the same umbrella. Of course, they're very heterogeneous in terms of what they look like and what the solution is, but we tend to talk about those things together when we're referring to child mental health. And the most common term used now for this whole umbrella of things is child behavioral health. So in the United States, we know that 1 in 5 children has some sort of mental, behavioral, or developmental disorder. And that suicide is one of the top 3 leading causes of death for children and teens. And that rate has been increasing since about 1999. It has been steadily going up. This figure to the right shows the prevalence of various kinds of mental disorders for children of different age groups. And as you can see, mental illness is much more common among older children and teens than it is among younger children. But of course, we do know that these disorders in some cases can start very young. Unfortunately, in the United States, we do have this issue of mental illness. And one of the biggest challenges that we face is our critical shortage of mental health providers for children. There was recently an analysis done of the child psychiatry workforce, and some researchers found that in the United States currently, 70% of US counties do not have a single child psychiatrist working in them. And those shortages are worse in rural areas. This figure on the right shows data from that study. The dark red counties show areas where the child psychiatry workforce is growing, and the light red show areas where it is shrinking or the same. And as you can see, there is a major problem in rural areas with losing child psychiatrists or not enough growth to keep pace with demand. We also know that almost half of Americans live in a designated mental health provider shortage area. That is defined as having 1 or less mental health providers per 30,000 people. Of course, again, thinking about the prevalence of these disorders, that's not nearly enough to meet the demand. And this shortage of providers is really a real issue and a big reason why we have such a crisis of mental health for children and teens. This is kind of the opposite graph showing in those mental health provider shortage areas, where is there the most need? And this graph really shows the opposite of what the previous one did, that in a lot of urban areas, which are shown in white, there is less of a need for child mental health providers, but it is the rural areas that really are struggling most to meet these needs and to have enough providers to meet demand for children and teens. When we talk about mental health providers, this is a very broad term that refers to psychiatrists, psychologists, social workers, advanced practice nurses, counselors, a whole variety of people. But those shortages, again, are really seen across the board and are worst for rural areas. So as you may expect, knowing that we have these shortages, only 20% of children with a mental or behavioral disorder receive needed care. That's a huge problem and a huge gap of underserved populations when we think about the scope of this problem. We know that unmet need for mental health care is worse for children without insurance, as well as children who are racial and ethnic minorities. And in the United States, surveys estimate that less than half of emergency rooms are prepared to address child mental health emergencies. Again, as you may expect, given the shortages in rural areas, these show up here too when we look at unmet need. This, I think this is my final map of the US here, and it shows in the red and darker red areas where there are higher rates of unmet need for mental health. The blue would be where there are lower rates of unmet need for mental health, although they are still very high. And again, in rural areas in the Southeast, we see that those areas of need are the greatest for children and for mental health providers. So, when we think about the context for this problem, I think one of the biggest achievements that we talk about in child mental health is insurance coverage. We now have a very good system where almost all children in the United States, not all, but most, do have health insurance coverage and access to pretty good coverage, at least on paper. But unfortunately, this insurance coverage has not solved all the gaps in unmet need for a couple of reasons. One is the inadequacy of provider networks. If you think about all the areas where there are shortage, having health insurance may not really do you much good if there is no provider to see you or no provider who takes your insurance. Another is low reimbursement rates for public insurance. And the final is piecemeal implementation of mental health parity laws. Again, on paper, all children are supposed to have insurance or at least eligible for it. And insurance companies are supposed to pay for mental health care at parity with physical health care. But the way that actually gets implemented and what happens on the ground is very piecemeal. It's different in every state and every county. And that is why we continue to see these persistent gaps, despite a lot of policy to try to advance insurance and insurance coverage for children. So that's the old problem. We're dealing with a situation with high rates of behavioral disorders among children, not enough providers, and high rates of unmet need. And then the COVID-19 pandemic happened in 2020. When the pandemic first started, there was immediately a lot of discussion by experts in child mental health that this was going to be a problem for mental health. A lot of people predicted that we would see a lot of problems because of social distancing and isolation. There was a lot of concern raised about online school, the extent to which that would affect development and cognition for children. There was concern about family stressors, death and loss of family members, economic stress, and then also a potential for violence and abuse. We know that when parents and communities are living in a context of economic resource deprivation and stressors like unemployment and such, child abuse rates can go up. And so all of these things were raised as concerns. But it's taken a bit of time for us to get actual data to really document these things and see what they look like. And as I'll show you in the next few slides, some of these concerns have been true when we look at the data, but some have been a bit surprising. So here's what we know so far from research. A lot of the early studies about child mental health came from countries that really were hit hardest by the pandemic first. So some of the first research that we saw on child mental health came out of China. And in China, an online survey with children and teens, they found that about 20 to 30% were reporting symptoms of depression and anxiety. That's not too far off from population rates that we see, but it does seem to be a bit elevated over that 20% that we see in the US. And they found that factors associated with worse depression and anxiety were identifying as female, living in an urban area, residing in the province where Wuhan was located. And of course, that was the original epicenter of the outbreak. They found that time spent on the internet and smartphone addiction was associated with worse mental health. And then also that children that tended to use emotion or problem-focused coping had more symptoms. So this definitely pointed to some distress among children, and specifically those children who might have lived in the hardest hit areas. In Italy, there was also a survey done with parents of children ages 4 to 10. And what was found in Italy was that about a quarter of children in this age group were showing regression behaviors. They were showing new fears and irritability, increased intolerance to rules. About 20% had mood and sleep problems. And there was also documented anxiety for children when they heard about the pandemic on home or on TV. Japan was the first country that I have seen to actually put out some data on suicides and to see if there was any relationship of suicide rates to the pandemic. Again, a lot of mental health experts were predicting that this would be a problem, but in kind of contradiction or maybe in some unexpected ways, we did not see that in Japan. There was an analysis of child suicide data, kind of comparing years up until 2020. And what they found was that there was no change to the suicide rate compared to prior years in Japan, despite the pandemic conditions. So that was certainly interesting to see. We have not seen great suicide data yet from other countries, but this one example of this one country does point to potentially not seeing this show up in suicide data yet. And then we turn to the United States. We have been one of the slower countries in terms of getting some of this research out, but there's great news that there is more and more coming every day. In a survey done of parents in the United States in June of last year, we found that about a third of parents reported that their mental health was worse during the pandemic. About 14% said that their children's mental health was worse. They reported a number of different stressors. Loss of regular childcare was a big one, increased food insecurity, and increased loss of health insurance coverage for parents. This survey also found that parents who had a greater caregiving burden, either for their children or for other family members, that burden was associated with worse mental health for parents. And this was an even stronger effect for parents who had mental illness. So this certainly similar findings to what we saw in other countries, that there seemed to be distress among parents and kids here in the US. Unfortunately, we also know that racism has been a problem in this pandemic, and that also is seeming to have a relationship with mental health for children and teens. There was a survey done also last year with Chinese American families. Both parents and youth reported high rates of racial discrimination, either online or in person, and were perceiving more discrimination in media coverage that they were seeing of Asian and Chinese populations. And higher levels of perceived discrimination were associated with worse mental health in this survey. So all concerns and pointing to higher levels of psychological distress across a number of different countries and in various ways for these different age groups. In terms of school closures and online school, this is probably the biggest thing that people have been concerned about in terms of the mental health and also the development for children. We're still waiting for more data to come out about how exactly school closures and online school affected the mental health of children. But last year, McKinsey did a good report where they looked at some of the changes to school academic achievement with online school and found that this was a really big concern. They found that students varying age groups and areas are anywhere from 3 to 12 months behind because of online school in 2020. There was a really interesting analysis that was done that projected life expectancy for the children of 2020 and actually found that the educational losses of 2020 could play out far into the future of these children in terms of their health, and may even lead to decreased life expectancy for this cohort. We know that there is a very strong relationship between education and health and life expectancy. And there were major disparities found also in this report by race and ethnicity. This figure here on the right shows the extent to which students are falling behind. On the x-axis, this 0 to 100 shows 100 would be that children are making all the progress that they usually do for their education level. And what we found was that for each of these different grades, as you go higher and higher up, the gains are the losses are accelerating, and there are more losses happening. The graph here also shows differences by race, ethnicity, and that children of color or schools that are in communities that are predominantly people of color are falling further behind their white counterparts. There also is data showing that Black and Hispanic students are more likely to be learning remotely than white students. This second figure here shows how many white students are in in-person or hybrid learning, and they are more likely to be in person than children who are Black or Hispanic, which is another concerning disparity to see. This final graph about schools shows that we have had big gains in access to technology. That's certainly been a concern, making sure that all children have access to online school, but there are still disparities that exist between white children and Black and Hispanic children in terms of their computer access and internet access. So it's improved, but we still do see disparities there, which are a big concern. And then turning to child abuse and neglect, this is another concern that has been raised, that we would see higher rates of child abuse and neglect. And that has seemed to be true from data that are coming out to date. There is evidence for increased severity of child and abuse and neglect injuries. There was recently an analysis done of emergency department visits related to child abuse and neglect. And what they found was really interesting. During the initial months of the pandemic, ED visits as a whole went down dramatically, but child abuse visits seemed to go up. And of those that they saw, the injuries, the severity of the injuries that they were seeing from child abuse actually worsened. And certainly this study pointed to some concerns about delayed or unmet need for child abuse. So this figure on the right shows emergency department visits in this study. The light purple line shows visits over time during 2019, and then the dark blue shows visits over time in 2020. So this line here is when the pandemic started, and as you can see, there was a big dip in emergency department visits right away in the pandemic, and they've kind of come back up to normal for as far out as the authors had data. The graph on the right shows child abuse specific visits. Again, the light blue would be 2019. And when we look at 2020, when the pandemic hit, there was a big jump in emergency department visits for child abuse and neglect. And when they looked at data for these visits, they seemed to lead to more severe injuries. So that's certainly a major concern when we think about mental health. I also had some questions about child mental health in my own practice as a nurse. I work as a child and adolescent psychiatric nurse in Los Angeles in a mental health safety net system. And I really wondered how the pandemic was affecting suicide rates for kids. I came to have this research question because I saw so many kids coming in the early days of the pandemic who were attempting suicide because of this whole new category of stressors related to the pandemic. And so I wanted to do a small case study to look at this and to see if there was anything going on related to the pandemic that might be consistent with the findings that we're seeing from other larger studies. So I'm going to talk very briefly about the results of this study. I wanted to know how COVID, online school shelter in place orders in Los Angeles were affecting suicide attempts for adolescents in Los Angeles. We know, again, from the studies I talked about, there's definitely this pattern of general psychological distress, but it's really hard to know if that leads to suicide or increases suicide rates. We don't have good data from the US yet. So what I found in the study in LA was actually fairly similar to what was found in the ED study that I just talked about. When we looked at our admission trends for suicide attempts for all the years leading up to 2020, we looked at 2016 to 2019, they were fairly consistent across the board. But when we got to 2020, we saw that there was a big decrease in our overall admissions, kind of like what was seen in the ED. But of the visits that we did see, about a quarter of them were related to the pandemic. And so overall reduced suicide attempts, but we did see this sort of new category of suicide attempts coming up that were related to pandemic stressors. For these adolescents, I did kind of a detailed case series looking at what was going on for these kids when they attempted suicide. The majority had a pre-existing psychiatric history, but for a small number of kids, it was their first ever mental health encounter. The stressors of the pandemic got so bad that they felt suicidal for the first time ever. For our patients, most of them actually attempted suicide. And again, most of them did have a pre-existing mental health history, but a small number had this as their first mental health encounter. When we looked at the reasons why they were attempting suicide and some of the stressors that led up to that suicide attempt, they really point to, again, a lot of these pandemic stressors that experts kind of raised the alarm about early in the pandemic. The most common precipitating events were kids feeling loneliness and isolation from their friends, as well as stressors related to online school. Those are absolutely consistent with what we know about adolescent development and the importance of school and friends in the lives of teens. There were other reasons as well. A number of these teens were dealing with family conflicts and trouble with being isolated at home with their families. Some had anxiety about the quarantine itself or even fear of contracting COVID. Some had loss of their usual coping resources in their communities, and then some were experiencing isolation from family in various ways that played out in their suicide attempts. These are a couple of examples of what these cases looked like. We had some kids who their means of suicide attempt was attempting to contract the coronavirus. Some are related to family conflict about leaving the house and sheltering in place. We saw a number of kids who are experiencing bullying, like cyberbullying via social media and devices. And then also some kids who were identified as LGBTQ, experiencing a lack of family acceptance and conflict at home, again, due to shelter in place. So these are just a few examples of the kinds of things that we were seeing coming up in our population. And again, I think the real takeaway here is that this really aligns with what we saw in other studies. We didn't necessarily see a big spike in mental health problems the way that a lot of people thought we might. We actually saw a decrease in service utilization and mental health seeking across the board, and that's true for all of healthcare. But of those people that did make it to care in mental health care, their needs were really severe. And certainly that points to a lot of probably unmet need out there that's going to continue to play out over time. A few other comments about this particular study that I did. We saw kind of there are multiple etiologies for suicide. Certainly, we know that suicidality can arise from mental illness like depression, but also suicide can sometimes be an impulsive act that arises out of acute stress in the heat of the moment. And in surveys of people that survive suicide, many people say that they are glad that they were not successful. And so we saw both of those etiologies. Some kids who were dealing with mental illness, others who were just dealing with really, really acute stressors. We know also from research there is a seasonality to suicide attempts and hospitalizations for children. They tend to go down during the summer and down in December, meaning that they track very closely with school. There are a couple of reasons for this. One is that experts think that there is probably increased recognition of mental health problems by teachers, counselors, and principals, and that those school staff may be more likely to call 911 for a mental health emergency than parents. And then the other is that at school, kids are dealing with many academic stressors or social stressors that might precipitate mental health crises. And so we saw a pattern similar to what it seems like in the summer initially in the pandemic. And going forward now, it's been almost a year since the spring of 2020 when this first started. We are seeing our rates of utilization really come back up to normal. And again, a lot of that unmet need that probably was missed early in the pandemic starting to come to us for care. So at that point, I want to move into the next part of this presentation, which is talking about possible solutions to both the old and the new problems that I've talked about. Again, we were dealing with a mental health crisis and a real problem with our mental health service systems prior to the pandemic. And then we know that there are a lot of stressors around COVID that are creating more psychological distress in the lives of children. So I want to actually pause out of my PowerPoint here and turn over to the ideas that you all had from our entry on Mentimeter. So let me share my screen again and show you what everyone thought of. I just need to end my PowerPoint here and I'll switch over. Okay, so here are the responses from this group. It looks like, and I'm going to just zoom in a little bit so that we can see this better. It looks like a lot of people think supporting kids in their context and going back to school are really important interventions that we should consider. It looks like definitely exercise, physical therapy, various kinds of community activities are showing up. Various ways of connecting with friends, maybe being via social media. I also see a number of responses related to going outdoors, finding safe places to exercise, and spending time outside. Those are all great. I also see a number of ideas for mental health interventions, things like peer support, therapy, counseling, psychoeducation. All of those are great ideas. It looks like the biggest one, though, up there is support, and that's absolutely right. I think the biggest thing that we need to do for kids and teens of the US is to make sure that we're supporting their mental health needs at home in their communities, but then also in our healthcare systems. It's very important that we think about how we can improve these gaps in care so that when people come to us for help, we are prepared to help them. So thank you for participating in this. With that, I will go. Oh, did we have a question, Althea?
Yes, sorry. So yeah, I just wanted to chime in with a few questions. So in regards to support, I thought that was a great topic that many people mentioned, because I think that's one of the things that everyone may not necessarily be aware of. In terms of nurses, for example, especially with telehealth, now we know that's been a big thing where you may not necessarily see the patient in person. What type of signs or symptoms would you say would be good to look for in children who might be experiencing mental health problems, who may not necessarily have a history of mental health?
Sure, that's an excellent question, Althea. Thank you. I think the biggest signs to look out for in kids and teens are changes to their mood or their behaviors or how they're functioning in their daily lives. Certainly seeing changes to friends, to grades, to their function in school or in their families. seeing things like increased isolation or withdrawal, increased outbursts sometimes, or more withdrawn, isolating behaviors. We call that internalizing and externalizing behaviors. Both of those ends of the spectrum can be a signal that there is something wrong. And, mental health can be really challenging to talk about because we know that there is a lot of stigma out there around mental illness, and kids and teens pick up on that very early. And so I think that if we see these signs, either with our patients or within our families and communities, it's important to first approach kids with an open-ended perspective and seek to learn about where they're coming from and what they're feeling in a way that they can trust.
That's great. And one of the things you mentioned earlier in this, when you were going through the studies, was the gaps in the remote learning for children of color or communities that are filled with children of color. And so, what do you think may be related to those gaps, like in regards to it being related to mental health? And do you think that's something that can be addressed?
Sure. So that's a great question. And it's one that we don't have the answer to yet in terms of how those school issues play out for mental health for kids. I think it's likely that they do have an effect. I think that being online is really challenging for a lot of kids. There's a small number of kids that I have talked to in my practice that like it and think it's better for them. But the vast majority, I think, want to be back in school because they are missing out on important connections with their peers and with their teachers. And for various reasons, being at home can also just lead to more stressors, certainly for kids who come from homes where there is abuse or neglect, for children who come from communities where there is community violence and where neighborhoods are not safe. School can really be a haven and a safe place. And so being back at home can sometimes be more stressful to kids. So I think that there is a relationship there. We don't have the research on it quite yet to back that up, but I hope that we'll see that coming out soon to understand more about what these disparities look like and how these online issues and academic achievement gaps play out in terms of mental health and development for kids.
Thank you. Well, and then someone is asking about the presentation. Will the slides be made available after the presentation?
Yes, absolutely. I'll maybe share them with you, Althea, and you can post them or
Great.
whatever would be easiest. And I'll also share this word cloud. This is really, I think it's great to see everyone's thoughts here. And certainly I hope that we will be able to offer some of these things to kids in the near future.
Definitely. Thank you.
Sure. So with that, I'm going to switch back to my PowerPoint to wrap up our discussion here about some of the solutions. So you all came up with some really wonderful ideas for solutions, and these are a few solutions that I am thinking about. So one is that we absolutely know that we need to expand the mental health provider workforce. That is a huge, huge ongoing challenge, and we will not be able to meet the need out there with health insurance coverage alone if we don't have people that can provide the mental health care. I really see nurses as a big solution to this mental health provider gap. We know that there is an advanced practice nursing degree in psych mental health nursing. Studies for a very long time have shown that nurse practitioners can provide equivalent care to physicians. And I think that making an effort to expand our psych mental health training programs for nurse practitioners would really help meet some of these needs. There's also quite a lot of research on nurse practitioners showing that they are more likely to go to rural and underserved areas than physicians. And I think this is another reason that we really need to invest in nursing training for mental health. Second, there are already a lot of nurse practitioners out there, many working in primary care and specialties, and it is possible for these folks to get a dual training in psych mental health and to get a certificate to also provide mental health care. We know that people increasingly are seeking mental health services from primary care, and so also would like to see more training offered to people in practice to be able to provide specialized mental health care. We do need to have more expansion also of child mental health training programs. Our kind of generic psych mental health degree for advanced practice nurses typically focuses on the whole spectrum of mental health, primarily adults. There are a small number of specialized psych mental health programs for child serving nurse practitioners, but they are few and far between. And so certainly we could benefit from expansion of these training programs. The final piece that goes along with this is it's very important that we think about expanding nursing scope of practice laws so that practitioners can practice at the full scope of their capabilities and their license. Well, the good news is that we have seen a lot of states do this during the pandemic, realizing that nurses are a really critical part of our workforce, and it's very important that they can practice at the top of their license to meet the needs for mental health out there. That's absolutely true for mental health as well. And so continuing to make sure that we are passing laws that are based in evidence and show that nurse practitioners can provide care and help meet a lot of our needs when it comes to mental health. Second, I would also love to see us leverage technology to help fill at least some of these mental health provider shortages and meet unmet need. There has been an explosion of using technology for healthcare and specifically for mental health. There are now video calling and texting options for therapy and visits with providers, and this is potentially a really good solution for people in rural or underserved areas to be able to access providers here and now while we have these gaps. Of course, technology is not a perfect solution. We know that not everyone has access to technology, not everyone has access to good, stable internet. And also there are still challenges with just lack of providers and insurance coverage that this will not meet comprehensively. But I have heard a number of examples of people who have really liked using texting or video or calling to interact with a therapist and have found that it's less intimidating and a less intense way to seek mental health care for the first time. I think that this is one way that we can expand access. Of course, I don't think that we'll ever be able to replace seeing people in person for mental health, but some people really prefer this and have found that it makes mental health more accessible and less scary. There are also a lot of apps out there for self-management and promoting mental wellness, apps for like mindfulness and doing cognitive behavioral therapy techniques on your own. I think those are great. Again, they certainly can't replace professional therapy, but for a lot of people, especially those children and families that might be dealing with increased levels of distress and symptoms, but not really fully at the level of needing clinical care, I think that using these resources and using technology to fill some of the needs is really something that's exciting and that will help some people quite a lot. Also, we know that there has been, all of us have been probably connecting with people more and more on technology. And I think that that is really a good thing as well to help people find social connection while we are isolated or more isolated than usual. Then I think that this is supposed to be a 3 here, but the third one is really thinking about using this pandemic as a window of opportunity. I have noticed so much decreased stigma around mental illness and around loneliness in 2020. I often see with children and teens that a lot of them are really comfortable talking about mental illness pretty openly, not all, but many of them. But often there is a generational gap between children and their parents, where their parents are hesitant to want their children to take medications or to have a psychiatric diagnosis. And there can be a lot of stigma in communities around mental illness. I think that the pandemic has led to sort of this universal experience of stress in some way, shape, or form. Of course, we know it's more so for some populations than others. But that has really, in my own practice, helped lower stigma for some of these parents and families to understand that their kids are struggling because of these external circumstances and to be really open to talking about solutions in mental illness in a way that I did not used to see. So that kind of universal experience of stress, I hope, can help lower some of the social stigma around mental illness and also around loneliness and isolation. That was also something that was very stigmatized and is still stigmatized. But I think that we have become more comfortable talking about ways that we are lonely and isolated and reaching out for help. Loneliness and isolation have been called by a lot of experts these diseases of despair, and kind of the biggest challenge that is on the horizon for us in terms of the future. We have made great progress in a lot of physical health disorders and amazing advances at treating so many kinds of illness and extending life expectancy. But these diseases of despair, things like loneliness, isolation, lack of social connection, substance use disorders are often included in this category. We don't have good solutions yet for these things. So I hope that this pandemic can also be a window of opportunity for us to do more research on these issues, come up with solutions that work, and then also leverage resources that already exist in communities to address some of these things. I'll end just by talking about a few implications for practice. I know that this audience certainly has a lot of nurses, nurse educators, and researchers, and people who are thinking very practically about these issues. Certainly, as I think I've probably made clear, there's an acute need for mental health support for children and adolescents who are experiencing this pandemic-related distress. There is a whole spectrum of distress, from experiencing some symptoms or stressors to children who are even at the level of feeling suicidal. And so we really need to have support for children and adolescents along this whole spectrum. Because people are not necessarily always able to seek care, one, because of the pandemic and limitations on healthcare access, and two, because of the pre-existing conditions of unmet need in so many communities, we really need to think about how we can help families and communities mobilize resources and strengths that they already have. We often don't do a very good job of that in healthcare. I think we often take a very problem-focused approach and want to tell people how to solve their problems, but we really need to have a reversal where we do a thorough assessment with families about what they have at home and in their communities that they can leverage, because we are dealing with these barriers to access and a pandemic context in terms of healthcare. Certainly knowing when to seek help. Althea already asked a great question about that. Seeing changes in behavior, emotions, any of those sorts of signs in children is a signal that they may need help. And then I also think it's really important that all of us in practice are using a trauma-informed care approach and a therapeutic alliance approach, regardless of care modality, whether it's in person or texting or video. Um, we just know, again, that there is this context of a universal stressor for everyone. All of us are dealing with family stress. There are many people dealing with interpersonal violence. And there is also a lot of grief and loss happening for children, with deaths due to COVID-19, and bereavement can be traumatic for some children. So what it looks like to embody these principles in practice, trauma-informed care is an approach to service delivery that really understands the impact of trauma on children and their health, recognizes it, responds it, and seeks to avoid re-traumatization in the process of care delivery. It's really a process from looking at patients and asking, what's wrong with you? Why are you having these problems? And what is your problem? To what's happened to you? What is the context that you're coming from? And how can we bring that context into the care approach? This box on the right from SAMHSA shows the 6 principles of a trauma-informed approach to healthcare. It includes creating an environment of safety, making sure that there's trustworthy and transparency between the clinician and the patient, having peer support available and recognizing that people can help each other just as much as we as healthcare providers can help others, that there's collaboration and mutuality in care, that we give patients voice and choice in their care and really empower them to lead their care decisions, and that we also are aware of cultural, historical, and gender issues that mean that there is a disproportionate burden of trauma for some populations. And then therapeutic alliance is the slide that I'll end on. Therapeutic alliance is something to me that has always been at the heart of nursing practice. And it really just means the working relationship between a healthcare provider and the patient. Often this relationship between patients and nurses is really the ingredient that makes a difference for people in their health, and that makes a difference for their wellness. And that is true for mental health as well. We have therapeutic alliance with patients and we have the same goals for treatment and agree on how we're going to achieve those goals. Many studies indicate that the most powerful predictor of treatment success in mental health is the patient sense of therapeutic alliance. It's sometimes less about what we are doing and more about how we are approaching patients and the relationships that we have with them. And so certainly building those relationships is a really big deal for people in their mental health. Psychiatric patients say that the #1 most important characteristic of their nurses is being a good listener. And so these are some really simple foundational relational tools that we know can make a really big difference for people in their recovery. So certainly would encourage everyone in practice to think about these principles when it comes to taking care of children and teens during COVID-19. With that, I will pause and see if there are any questions from the audience. Thank you all so much for listening today.
Great. Thank you so much, Kristen. That was a great presentation, very informative. And I think we actually did have a few more questions. One of the topics that came up was this concept of school nurses. Someone asked, do you see schools bringing back the school nurses? in all the schools as a result of COVID-19. Apparently, currently the school nurses are serving many of the schools now, I guess, instead of being in place in one school. Do you have any thoughts about that?
Yeah, absolutely. Unfortunately, over time, we have seen a real erosion of school nurses and school nurses being decreased and having, as this person pointed out, one nurse serving a whole district in multiple schools rather than in a single school. I think this is a huge problem, and I hope it is one that we change with the pandemic. I have not personally seen any movement towards that yet, but I hope that the pandemic has brought attention to the numerous roles that nurses play in healthcare, including school health and public health, and that going forward, we increase the presence of nurses in schools. I agree completely that this is a really important intervention and something that would really help our kids in terms of their mental health.
That's important. And like you said, hopefully, things will change as, things continue to get better. Another question that came up was in regards to the confidence of students and their comfort level in seeking help. So, how do you develop confidence in young people who may not be comfortable seeking help or support for any mental health issues, even though they know that the resources are available?
Sure, absolutely. This is one of the most difficult parts of mental health care. It's very hard, especially as a child or a teen, to recognize the need for help. And sometimes we, as adults in the lives of children, whether we're nurses, teachers, parents, community members, need to help them see that need and point that out. I think a big part of it absolutely has to do with generally decreasing the stigma around mental illness and helping kids know that it is okay to be struggling. It's okay to say that you are sad, that you are afraid, that you are lonely, and to make clear and to model to kids that it's okay to talk about those things and to also model what it looks like to ask for help. But I think for kids and teens developmentally, when we see those changes emotionally or behaviorally, even if they don't really feel like they need help or want help, we as adults in their lives have certainly a responsibility to get them that help. Certainly, if we're talking about a psychiatric emergency or kids who are at the point of suicide.
That's true. And I think that's another thing that's really important. You showed us slides about the suicide rates. And, it's interesting to see that, in some countries that this hasn't, the rates haven't increased, thankfully. And I think that's another thing, even though they may have had more attention while they were in school, now they're at home. So hopefully, that's still helping in terms of getting the attention and the help that they need if they're struggling or dealing with that.
Yes, yes, absolutely.
Mhm. Sure. And so at this point, I just want to see if there's any further questions. I don't see any in the chat. Many thank yous. We truly do thank you so much for your time today and for, actually taking the time to prepare and present this presentation. Like I said, the information was definitely very informative. Everyone can see Kristen has her information there. If you would like to get in contact with her, she has her email at krchoi@ucla.edu, or you can follow her on Twitter at Kristen R. Choi. So thank you again so much. Thank you to all of you who joined us today to attend our webinar presentation. We look forward to having many more. And again, we appreciate all of you taking the time to spend with us on this important topic of children's mental health. If you would like to actually participate in presenting a webinar, please feel free to contact us at our email address, info@jonasphilanthropies.org. Thank you again, Dr. Choi, and thank you all for joining us today. Everyone, have a great day.